Welcome. My name is Kelly Piper with the California Healthcare Foundation. We're delighted to invite you to join our office hours today. These office hours are part of the Opioid Safety Coalition's network, and we'll be bringing you offerings every month for the next 18 months focused on safer prescribing, on medication-assisted treatment for addiction, and on spreading access to naloxone to prevent opioid overdose deaths. The California Healthcare Foundation supports 24 counties across California, organized into coalitions that are bringing hospitals, medical societies, addiction treatment, community advocates, clinics, and others together to together come up with ways for the local community to have safer prescribing practices and fewer bad outcomes due to opioid overdose and opioid overuse. We're inviting Dr. Marshall Kubota from Partnership Health Plan. Dr. Kubota is a regional medical director at the health plan, was previously a residency director at the family medicine program in Santa Rosa, in fact, my own residency director when I trained, and had previously worked for a long time as a leader fighting the HIV epidemic, both as a family doctor and HIV specialist. Partnership Health Plan over the last 2 years has been a leader in fighting the epidemic. They have created a program called Managing Pain Safely, which you're able to see on their website. If you Google Partnership Health Plan Managing Pain Safely, you can learn about everything that they've done, from educational opportunities and trainings to leading and supporting local coalitions and changing their formularies and having policies which help physicians practice according to the evidence. So we asked Dr. Kubota to come here today to reflect on how they did it, to bring 14 counties with physicians like myself, none of whom, we don't like to be told what to do. We don't like to follow common standards. We're notoriously difficult to change once we've got in our head a certain way to practice. And that's a real problem in the opioid epidemic, since all of us were trained in one way of thinking, and now a whole new body of evidence is teaching that that way of thinking is wrong. So the office hours format is fairly informal, and there'll be opportunities to ask questions and have discussions over the next hour. We'll start off with Dr. Kubota speaking. We'll put you on mute, and then we'll unmute the lines to be able to have a discussion. So Dr. Kubota, thank you so much for joining us today, and we really look forward to learning from you.
In developing community prescribing guidelines, to define the community. Now, the focus of today is primarily in primary care, and there are many other points in opioid prescribing that have similarities, but really these other areas have differing facets that result in sometimes markedly different approaches. So if we work with primary care, let's not forget that we also have to deal with all those other what I call leakage points, emergency departments, urgent care centers, specialists, hospitalists, dental, the behavior of pharmacies sometimes, even hospice care. Don't forget the medications that are prescribed to a hospice patient are their property. So if that patient dies, those meds cannot be taken back without permission. They belong to that individual. And so there are, again, and then the whole area of the illicit trade that goes on. So, and staying with primary care, though, what we're doing is kind of breaking a tradition or breaking a habit, as it were. It's our own habit, and it's an unfortunate one that began, of course, with treating cancer pain and the undertreatment of cancer pain that, with the advent of synthetic opioids back in the early 90s, expanded to the treatment of all pain, and that we had an obligation to treat pain. And of course, at the time, with the new synthetic opioids, which had the promise of being effective but perhaps not addictive or dependence, came out. So we had pain as the fifth vital sign, the only, of course, non-objective vital sign of our vital signs. And that was kind of foisted upon us with the visual analog scales and the smiley faces and all of that, sometimes by our policy agencies to do that. and forms and calculators, things to estimate the risk of dependence and abuse of our patients. Some of these calculators never said don't prescribe, but to monitor more carefully. Whereas other risk assessment tools, for instance, the ones that we use at Partnership, the Dyer tool says you should not prescribe to these individuals. It just flat out says that the risk is too high. So we all know this large cohort, and it is a cohort phenomena, was developed in the 90s and 2000s, because if we look at the advanced elderly, their rate of narcotic use is not as high. They missed the party. They came too late to the party to be prescribed these high dose and chronic opioids. And as a result, we hear, and I know you all hear that, particularly and to some extent from the younger clinicians coming in, that we inherited these patients, or a clinic, they transfer in. I think the same cohort of patients is moving around, and indeed may have been created in those times, but not all were inherited, and our younger physicians may not have started this runaway train, but many of them did jump on board. At Partnership, we took a look at the latter half of 2013, and patients on chronic opioids, about 30% of them had an increase in dose during those 6 months. So inherited and enhanced upon, unfortunately. So we all know the result of this, but I think it bears some thinking about, because these are important in how we develop our community, how we develop the importance of addressing this problem. So for the patient, of course, first of all, the chronic opioids oftentimes ineffective. That's why the dose kept going up. And, the ineffectiveness of opioids for chronic pain, I think, well documented. And then they become high dose dependent, high side effect profile. Some become addicted. There's the overdose problem and diversion as a always mysterious issue that gives us a great deal of insecurity as clinicians. And there's when you go to these opioid discussions, oftentimes there's a tendency to concentrate on the top of the pyramid, the capstone, as it were. And that's important, the overdoses and the mortality and hospitalizations. But understand, beneath that top of the pyramid are so many more individuals who are just plain miserable. They are on high-dose opioids. They're miserable. They still have pain. And as it's been often said, I don't take the opioids to treat my pain. I take the opioids to feel normal because they're so dependent. Now, for the clinician, and we all have this issue, and, a great deal of dissatisfaction with our primary care practices because of the amount of opioids, ineffectiveness, helplessness. I think probably maybe more than anything is helplessness on the part of primary care docs, because they just have to keep doing it. They know it's not a good thing to do, but they have nothing else to do, and they keep doing it, and the patient comes and they want increase in dose, and there's, some just surrender to it. And I understand how that happens, and there's guilt and fear, suspicion of the patient. Boy, that's just not a nice thing to have in a patient-doctor relationship, suspicion that they are selling or diverting or using other drugs, and then a lot of pressure from the system to see patients, right, the volume-based practices, and then, again, the great dissatisfaction in primary care as a result. For healthcare systems, of course, all these appointments for prescriptions displace care for other individuals, and oftentimes, of course, divert the care that is necessary for the patient on the opioids, because all that they want are their prescriptions. All you want to do is get them through the appointment, and you miss other things in their care. And of course, the cost, the pharmaceutical costs, hospitalizations, emergency department visits, and the like. And what about recruitment and retention? You want to recruit primary care docs? Put in place a well-thought-out plan for pain management and Schedule II prescribing in your community. And I think the important thing there is community. Practices should work in a community with their community in order to get these policies done. And there are the effects on law enforcement and public safety with diversion, overdose, motor vehicle accidents, poisonings. All of these as well spell out a lot for both law enforcement and public safety. But we deal with a great deal of difficulty in behavior change. It's really tough. This is the clinician's dilemma. We know that over 90% of individuals who are hospitalized, this was in the Annals of Internal Medicine, hospitalized with an overdose in the following year, receive similar or the same drugs as they overdosed on. And it seems, wow, that doesn't make any sense, but that's the dilemma that clinicians are faced with. Sometimes they don't know, I understand that, but oftentimes they do. We know that as well, and they still get prescribed the meds because the patients still have pain or say they have pain. Again, suspicion, right? And so what to do with that? It's a behavior change. So people want to please the patient. It's one of our scores now, pleasing the patient. We want to treat pain if indeed we can quantify it, which is hard to do. Again, dissatisfaction. Good training for making the diagnoses of the pain and where it is, especially the axial skeletal pains. The pressures on clinicians of volume versus quality, and that argument can go to many areas, but where you have to see a lot of patients, it would take time to either convince patients to reduce pain meds or to make a good diagnosis of what's causing their pain, and have that difficult discussion when indeed you have pressures of volume production in practices. A lot of misconceptions about pain treatment, including the ineffectiveness of opioids in chronic long-term pain, and sometimes inappropriate prescriptions. Pain is not in the pathway for chronic headache or fibromyalgia or peripheral neuropathy, and yet, commonly prescribed for those ailments. People don't like to have the difficult discussions. They take time, they're uncomfortable, they create arguments, dissatisfaction, and so there's an avoidance of that with patients. And when the numbers are large, like they are with prescription opioids, it makes a big difference. If clinicians cannot prescribe opioids, they want alternatives to that. Now, the United States prescribes over 85% of the world's opioids. I don't think U.S. Patients are wimpier. I think Donald Trump would say they're not wimpier than other patients, and yet we prescribe most of the opioids, and Vicodin, or its generic, is the number one prescribed drug in America. So we do want alternatives, either prescription or non-prescription. The importance of medically assisted treatment to be developed as well to help with the behavioral change in our clinicians and alternatives, and then non-medical treatments as well. Whether that's movement therapy or classes or things along those lines. Prescriptions that are non-opioid, for instance, the SSRIs that may be effective, medications for peripheral neuropathy, all of these the number one recommendation, of course, of the Rheumatology Association for Osteoarthritis is acetaminophen, right? Because you're not going to treat the arthritis, you're not going to stop osteoarthritis. You have to develop a change in expectation for the systems, for the clinicians, and for the patients too. That we don't want to do them long-term harm, but that's a difficult thing to get across. And again, it sort of adds to that helplessness of clinicians and their dilemma in working with their behavior change. But do they want to change in the system? Absolutely, they want to change in the system, but they need support. So part of what we do is to work to provide that support for the prescribers so that they can change. Education, of course, is a big piece around that. about chronic pain, about the epidemic of prescription opioids and their ineffectiveness. Team-based care, take the weight off. We have team-based care for diabetes and hypertension and the prenatal care, but this, again, soaks up a lot of clinicians' time. It's a big problem, both the opioid prescriptions as well as chronic pain, and there should be team-based care around that. But I think one of the big things, and one of the things we're to talk about today are development of community guidelines, but I'd like to make a little differentiation between guidelines and policy. They sound alike, but they're not, right? Guidelines are informed. They are widely applicable across entities, right? So you have the state of California guidelines about treating chronic pain. You have the CDC guidelines, widely applicable, but they allow for interpretation and variable application depending upon the nature of the situation. So they're good, they guide us, but they can be variable, and guidelines in and of themselves may not result in the desired degree of change unless guidelines at some level or another become policies. Policies act to, reduce or to remove choice from in interpreting guidelines, and so it's the application of guidelines in perhaps a more stringent, not necessarily narrower, but more enforced fashion. So it removes, in many cases, relieves the responsibility from the prescriber. And it's one of the key issues that they can sort of, and we see this as with Partnership Health Plan or a Medi-Cal not-for-profit, pass the blame. And that's okay. At the front end, that's okay. Your insurance company will not pay for this. Or our health center's policy is this. And so it kind of allows the clinician to pass the culpability of their actions to a policy which is informed by guidelines. So as far as policy goes, it reduces variation between the entities. Those entities can be counties or practices or prescribers. It depends on how parochial a region you're looking at. So it reduces variation. Guidelines do that too. Policies enforce it somewhat more. Now, you have to be careful as you put together policies not to violate things like the corporate practice of medicine. So there are guidelines that help to inform policy. There are questions out there about this point. I put these things together because I suffer many of these same issues.
Hi, this is Brian Koch. I'm calling from San Luis Obispo County. I'm an emergency physician, and we developed a coordinated care plan in our ERs, and I think it kind of uses that pass the blame model. We effectively, have a committee that meets that, for people that are frequently using the emergency department for prescription pain medications, and the committee makes a recommendation that they will no longer receive opiates, either in an injection form or prescription or any opiate of any kind, and we feel that their pain would be better managed by a pain specialist. Do you think this is an appropriate use of this pass the blame? It actually has been an effective program. We've had it used for the last 3 years. Want to know your thoughts.
Well, that's a great point because it brings up two things. One is that your internal policy empowered your clinicians to say no, and that's number one. Number two, emergency rooms as an access point, right? Nobody wants to be the easy touch emergency room. Now, when you work with emergency rooms and opioid policies, once again, nobody wants to be in the shallow pan of water. Nobody wants to be the low end of that pan, right? Because those who are drug seeking, and that is a subset of those who are prescribed opioids, a subset of those with chronic pain, but those who are drug seeking rapidly find the low end of the pan. And to that extent, both in emergency rooms as well as the communities as a whole, people should move together. It's better for the community. It's better for the practices. It builds a good community sense as well. So emergency departments as well as urgent cares should all act similarly, or they become the low end of the pan. Nobody wants to do that. But I applaud you in that. I know that the College of Emergency Room Physicians, of course, has their guidelines, but they're only guidelines. If you read them, they're kind of soft, right? And then you use those guidelines to inform for internal policy that helps direct your clinicians. So yes, I think that's exactly the kind of thing we're talking about. Emergency rooms, the emergency departments, urgent cares are a little different than primary care because of the long-term commitment, although for some EDs it is a long-term commitment to the patient. But I agree with you entirely. Now, are there other comments or questions?
Yeah, I have a comment. This is Glenn Siegfried. I'm an ER doctor, and I work in Fortuna, California.
Hi, Glenn.
Hi. So, in addition, I want to add to what the previous doctor said. We have adopted the ACEP patient handout regarding safe pain medicine prescribing that delineates what we do and don't do for chronic pain, and we hand that to the patient so that they understand what the ground rules are for chronic pain management in the ED. It also has a local phone number for alcohol and other drug treatment programs. So it's something tangible for the patient to look at that lays out the ground rules.
I think that's one caution about handing out those guidelines is it should happen only after the patient's registered. I've heard people being concerned about it being a EMTALA, am I right? EMTALA, to have it posted before patients are registered. So I would recommend that if you do that, if you have these things posted or you hand them out, that it only be visible or available after they've registered to the department. But yeah, I agree with you. The final step in some of this kind of passing the buck to policy, which is a fast way of doing things, is that the clinician agrees with the policy. So it's like we have this policy and I agree with it is kind of the final conversion of clinicians.
Yeah, I totally agree with your statement. We do not hand it out until we've evaluated the patient, and I usually hand it out as part of their discharge package.
Excellent.
But yeah, it would be an EMTALA violation if we gave it before we'd completed our medical screening examination.
Perfect. That's good advice for everybody out there in the development of guidelines, particularly for the emergency room.
And this handout is available on the Cal ACEP website for those sites that would like to adopt it.
Yeah, it's similar. I know to Marin County's guidelines are almost word for word similar to that. And, guideline informing policy directing clinicians to the extent that you can do so.
Great. So, Marshall, why don't you keep going and talk a little bit about the community prescribing? Because the ED is a good way to kick that off, as there's many communities where the emergency departments have all adopted these guidelines, but the primary care and the rest of the community is often not part of that discussion, and so that's a big reason why we are supporting coalitions.
Yeah.
So go ahead, and then we'll have other times for questions.
That's great, Dr. Piper. So one of in successfully walking with that shallow pan of water, we've all kind of done that in our real lives. The first rule, I think, for community prescribing guidelines is do it as a community. I think it's important for the community to move together. And there are various definitions of that. A community can be defined as a region, let's say a county, or for I heard the folks in the CHCF grant from Los Angeles. Of course, it's too gigantic. They might need to divide the county up more regionally, and I can see that. And one of our counties, we work with Mendocino County, has two big population centers, and they have difficulty getting together because of the distance. And there's a small county where we may, again, look at these types of developments separately, only because of geographic separateness. So there are various definitions of what this community may be. It may be by types of practices. It could be FQHCs or rural health centers and the like. And sometimes they have associations, of course, where they do it that way. And so lots of definitions on this. Do it as a community. Why do it together? Well, inclusiveness, of course, is important. We want to bring everybody in. Influence, greater influence. Unity. You want everybody to behave the same. Again, you don't want to be the low end of that pan of water. Unevenness in prescribing patterns are quickly discovered. We have seen a recommendation for opioids in a Yelp review. Go to this clinician. And if you don't move together and somebody moves in advance of somebody else and that pan is tilted and patients rush to another practice as a trial, it can cause discontent in the medical community. So I do recommend as you look at putting together these groups that you do all you can to move together. Another one that's an interesting one is marijuana. Some practice say yes to marijuana, that we're not going to test for it or co-prescribe. Others say absolutely not, and that can cause that same tilting of the pan. Just something to be cognizant of and careful as you move as a community and doing it together. So how do you create that community? Well, part of it is that kind of burning platform analogy, the urgency. One of the things that, and I think we discovered this in partnership when we began a couple of years ago, is that there was a lot of systemic tension around this issue. I mean, a tightly coiled spring. And it's important to be able to recognize that tension in a community. Everybody wants to do something. So recognize it, create it if the information is not there, because it's there. The problem is there, but the tension may not be created yet. The mortality statistics, the prescription numbers. We know these things. More people die of prescription overdose than of automobile accidents. More people die of prescription overdose than handgun-related homicide, firearms-related homicide. So, there's gun control and there's prescription control. If we could do the latter better, we'd save more lives than, Anyway, so just keep that in mind, that the prescription pad might be more dangerous than bullets. So, anyway, so that tension is there. We know it's there. We should utilize it to bring a community together. And there's lots of data out there. There's national data. There's statewide data. And local data is very, very helpful. County prescription rates and the like, very useful for building the argument for your community, however that's defined. Overdose and poisonings, morbidity, mortality. The College of Wisconsin's county health rankings has that as one of the sections. And we work in one of the county's partnerships that has a poisoning rate 4 times that of the state average. And so, it builds that burning platform. It creates that tension that we can use to bring the groups together and move things along. Now, there will have to be in moving these communities together, who comes to the table, who's part of those communities, and you have to have leaders. And the leaders can be, you never know where you get your leaders. But, commonly it's public health, of course, and it can be insurers depending on your setup. So partnership is a county organized health system. We're the only Medi-Cal providers in the 14 counties, for the most part, in the 14 counties that we serve. And so we were able to be a nexus, along with the California Healthcare Foundation in other counties, to help lead the process and become the leaders and the captains and create the tension, utilize that tension to bring people together. Again, who are the invested parties that you want to bring? Again, a little bit depends on how you cut the cake, right? Practice settings, regions, counties, and some overlap. I talk about you don't want to be at the low end of that pan of water. You don't want to be the county next to a county that's doing a good job either. This stuff spreads pretty quickly. One of those high risk items when you look at patients requesting opioids is how far did they travel? Well, if you have a community or county that's doing a good job of bringing this together under some control, your patients will travel to other counties or even out of state, and we see that in some of our border counties. And so, the boundaries can get wider and wider. And there are, of course, great benefits of working together because you've seen one. Every community is a little bit different, has different resources, both within their communities, particularly in terms of alternative therapies, and kind of workforce power, say with their public health departments. And when you bring people together, you'll find out that people are in different stages along the evolutionary pathway. Some are advanced, some haven't started, and really what you want to do instead of diversifying because that unevens that pan, is to coalesce, is to begin to act together. And this goes for the emergency departments. Were there 80, I don't know how many emergency departments, over 80 urgent cares in LA County. It's just incredible what LA has to work with in terms of size. But to coalesce the groups, make them more alike than different, move together. You have to keep the fires burning. So you have to keep that platform burning. You want commitment, so you need data, because data that shows benefits. Well, first of all, data helps set the fire, and then particularly if you follow data outcomes, that kind of upside progress helps continue to feed the fires, keep things going. And when you get together, one of the things that's happening, of course, is that we know that there's a lot of movement, even without organized movement. And so the tension in that tightly coiled spring is letting off a little. That doesn't, it can be letting off, but there's still unevenness regionally that you want to coalesce. That is a reason to, again, build tension in that spring, and there's a lot to do still. There's still, even if they have primary prescribing practices, there's a lot inside of that, just that statement. And so there's still a lot to do. There's still a lot of tension in that spring. And, clinicians, again, welcome the changes, but they need help, because some of that actually they have to perform. And so we do have to help them out. We can help them out with policy, but the final application of some of that policy is the clinicians themselves. So keeping the fires burning, again, lots of guidelines available out there. The CDC has theirs, State of California, State of Washington. Partnership Health Plan has modeled theirs after the Southern Oregon prescribing guidelines. Partnership Health Plan has their own guidelines, and we have our own toolkit. It's on our website under Partnership HP, as in health plan, partnershiphp.org. We've got our toolkit that's divided into critical reading and other, because there's a lot of other. And, of course, guidelines need to be modified to meet local needs, and develop goals and the purpose of your groups that get together. You do have to bring them together. But I would set those goals high, because there's a lot of cream at the top of this problem, a lot to be skimmed. It moves pretty quickly. Partnership Health Plan, our plans began in 2014, and we're down 50%. In almost every way we look at opioid prescribing, we're down about 50%. Number of high-dose patients, total amount of prescriptions made, initiations of opioids. And so I set your goals high, and our goals are 75%, because there's a lot of because the tension's so tight. People want to act and move. So I recommend you set your goals pretty high. But once you implement, it's going to cause a lot of row, And so I think everybody has to be prepared for that.
Dr. Kubota, how did you get prescriber input into your guidelines?
We have meetings, we have clinician meetings, and we partnership put a lot of effort in this. It's an entire initiative that involved every facet of our company, from the top down: administration, board of directors, our provider relations, our customer relations, our pharmacy, our clinicians, our medical directors, all the way through. It's even part of, we have a pay for performance. It's part of our QIP, our Quality Improvement Program. Our pay for performance program is about this. Now, it's relatively simple parts about this. It didn't have any actual prescribing amounts, but it talked about registering for cures, just things like that. But we did put a lot behind it, and we brought in groups, and it's both ways, Kelly. We brought in people to set up our guidelines, informed as well as having practitioners, and we're participating in our communities. So it's both ways. And for some communities we play a bigger part than others, but it's both. It's both. We participate in and we brought in.
So Dr. Kubota, one of the things I heard is that you really did it within one day, because the developing guidelines could take a year if you debated every fine point. So do you have any, I'm just trying to imagine, you've got a room full of doctors, everyone wants to decide for themselves, it's like herding cats. How did you get this room full of doctors in one meeting to agree on some of the main points of your guidelines?
Well, it's one of those, I think it's one of those things that you work in development of these types of things, is that you have a group, a smaller group, that looks at current guidelines. What do we want to do? What do we think we should do? And then we present it as a finished product and then let people modify it, as opposed to trying to build from the bottom up. And there are a lot of guidelines out there that we use primarily the Southern Oregon guidelines, which may now actually be a little bit behind the times, and then presented it and then asked for a comment and modification. I would recommend, like I said, it can cause a row. And part of the preparation was, and we learned this early on, was our again, as a Medi-Cal insurer, that we didn't fully, it didn't take long to figure it out, but we didn't fully inform our member services of what we were doing. And so member services was working, we will work with your doctor to get you your opioids. And on the other side, we go, no. And so I think in a community, again, and this is where you bring in, this is where that the rings begin to enlarge. Your pharmacies, your hospitalists, your surgeons, your urgent care, your EDs, again, where you should, and they should all be, they may not have to be a direct part of what's happening at this point in time, but they need to be informed of what's happening. And that's a good thing to do, so they understand where it's all coming from, and we all kind of row in the same direction.
I think that applies no matter what system you're in. When I was in a community clinic and we did guidelines together, we realized pretty quickly we had to involve the front office and the medical assistants, because everyone touches this problem. So whether you're in an emergency department, a clinic, a larger medical group, making sure that the customer-facing side of your organization really understands what you're doing is important. And I did want to just call out a couple examples of that shallow pan problem. When in Oregon, the county clinic system decided to clamp down on overprescribing, they lost a lot of patients, and the community clinics around the area found themselves overwhelmed with people coming in with high-dose opioids and demanding help. And we've seen the same thing happen in Lake County, where one medical group said, we're just not going to treat pain anymore. with opioids. So if you want opioids, good luck, find some other place to go. And again, the more these types of conversations can happen as a community, the better. And Marsha, I was wondering if you could comment on, because there's so many things to decide, have you ever looked at what would the top priority things be? Because as a community, could you agree on just we'll try to avoid high-dose opioids, or as a community, we'll agree on trying to get people off combination benzos and opioids? If you're going to say what would the top priorities for people to work on, what would those be?
Oh, it'd be it's setting a dose limit. I think that's number one. And whether you take the CDC's 90 MEDs, we chose Southern Oregon's 120 morphine equivalent doses. I think those are the amount prescribed, not allowing more than that prescribed. And if you're above that, looking at those patients, looking at tapering those individuals down, because it's probably it isn't ineffective, and they're miserable patients. So that's not the capstone, that's not the top of the pyramid, but it's certainly a significant, it's the misery-causing part. It's miserable for the practice, the clinicians, and the patients. So I think that addressing the high-dose opioid patient is first. And that there's more than just the prescribing limits. There's alternative therapies. There's referral both to behavioral health and potentially AODS and the like. But I think the high-dose patient, whether or not they have verifiable pain or have pain that needs to be addressed in other ways, that would be the top. When people talk about it's difficult or how to taper, I think that is really what they're asking for is how do I talk to the patient? How do I talk to the patient about it? Because tapering is not hard. In the end, tapering is not hard. It's less than you prescribed last time. That's a taper. Well, really what it is how do I have that discussion? So I think, empowering or not only having these doses, that's kind of a practical, objective goal. But the subjective goal is working with the clinicians to have those discussions and to work this system down and to address the problem.
Any other questions before Dr. Capote proceeds? All right, so feel free to speak up if you think of something, but otherwise, Dr. Capote, keep going.
Oh, great. So if we look at the communities as they come together, and I encourage you again to define that community and bring people together. Of course, there's a lot of the non-primary care. We have the ED docs, a good example of that, where you want them to work with you and to work and march together. But opioids, there are a lot of subcategories to these opioid prescriptions. Everybody thinks it's just one animal. It's not. There are the current patients on high dose, however that's defined, whether it's the CDC or say Southern Oregon's or Washington's. There's a question of do they maintain, do they taper, and how do we help our clinicians have that discussion? Escalations. You have to be, escalations. We see escalations in people on high doses. Now, most of the time in medicine we call that futility. And so escalations in people already at high dose. Medication-assisted therapy, Suboxone. I think this is an area that needs to expand, and we need more, I think, Suboxone clinicians with the X license. I think there are a lot of curious clinicians out there who know about Suboxone, considering it, but what are they getting into? So they're a little concerned. And I think we need to do a little bit of education and information about what Suboxone does for the patient, what it means to you as a clinician, and what it means to your practice. So all three have to be addressed for the Suboxone and medication-associated treatment. Naloxone use, right? We see a lot of it more in the press now. The distribution without, is it Walgreens, right? A kiosk that will dispense naloxone. That's incredible. I think that's great. I look to increase the ambient amount of naloxone in the community. So it's not necessarily the person themselves who've overdosed, but somebody around them has naloxone and can administer it with a low barrier for administration. So you have your high dose. You have the people who want to escalate, right? And you have to be able to address escalations. So that's the second group. The initial prescriptions. That is, partnership's next goal is look at initial, because we know that patients who have been on narcotics for more than, 60 days? 2 years later, half of them are still on the narcotic. So there's a problem there. Initial prescriptions, are going to be watching those extraordinarily carefully so that initial to chronic doesn't happen when it doesn't have to. And the only way you actually reduce the space that chronic opioid patients take up in the clinic is to not have so many. So whether they're on 80 or 240 MEDs, they're going to take time. The only way to free up that medical time is to not have them. So that's why initial to chronic becomes important.
Dr. Kubota, could you talk about specifically how you're going to implement your policy that will limit use? Because it's very interesting.
We're in the early development stages, but we're looking at what post-operative and acute prescriptions, how long should they be? And we're in discussions about, anywhere from 3 to 7 days. We're not looking at a 30-day. We're absolutely not looking at a 30-day prescription. I don't know how short it's going to be, but it's not going to be 30 days. We're not going to allow 30-day prescriptions. You can re-prescribe to the shorter amount that we're going to determine, but we're not going to let 30-day new prescriptions go by. I don't think so. Except, there are exceptions with hospice and the like, but otherwise, we're not going to do that. So we don't know what the number is yet, but we're thinking about it. The other group is that capstone, the top of the pyramid group. And you all may have seen that internal medicine, annals of internal medicine, right? 91% of people who overdose still got a class 2 narcotic afterwards. It's just like, oh my God. So we're going to work that group as well. Now that is the top of the pyramid, both with naloxone as well as looking at those prescriptions. The way we're going to do it, though, is we're working to see to it that the prescribing clinicians are informed, because oftentimes they're not, that their patient was hospitalized with either an overdose or intoxication, actually. We'll look at intoxication codes as well. And so that's how we're going to work that. So that's good for the ED docs out there to know that we're going to work to inform the primary care docs that, by the way, your patient was hospitalized with the drug that you prescribed. So maybe they'll do something about that.
I really want to call out your comment about guidelines versus policy, because a lot of us in practice, we deal with one patient at a time. So sometimes guidelines have no impact on our practice because we can't remember them all, and they don't help us with that difficult discussion in that moment. And that's where policies at the clinic level, practice level, hospital level, or health plan level can be really helpful in backing you up. And so I think that's one pearl I want us all to take from this conversation is, in your organization, think about when you can hardwire a policy that can give your prescribers something to back up. And if you don't have that because you're not in an organization that has the ability to hardwire things into an electronic health record, then having a health plan ally or having leadership in a larger system can be helpful. And CHF is working with health plans across the state who will start to be implementing more opioid safety measures. So if you aren't directly working with a health plan in your county and you would like to and you're not sure where to start, please reach out to CHCF, because health plans can be great partners in this effort. They've got data that prescribers don't have. They have the ability to deny or pay for medications that prescribers don't have. They can identify people going to multiple pharmacies and be able to hardwire locking into one pharmacy or one prescriber. Because we all have contracts saying you should only use one prescriber, but there's no teeth in that, where a health plan can provide that.
Yeah, that's great, Kelly. I appreciate that. Yeah, policy versus guidelines.
Any questions before we can wrap up to the last part of the office hours? Any questions or comments? Okay, do you want to say a little bit about outcomes and your plans for the future?
Sure. So in terms of, first of all, I think, one of the things you do have to have is our data. Our data. Develop a dashboard. Whatever kind, with the elements that you can get, for which you can get data, and show progress and change. I know part of that data is oftentimes mortality and poisonings. But again, the top of the pyramid, I encourage you to look at levels below the top of the pyramid as well, because that's where a lot of your change work will occur. And the top of the pyramid is kind of shaky because of the relatively low end. So create dashboards. I think that's an important thing to do. Use your insurers, use your cures data for that. In terms of outcomes, so you have to have the data to show the outcomes. And, as I said, right now, because we have claims for opioid partnership, and then this is how you can work with your insurers, we have about a 50% reduction in total morphine equivalents. I joked at one time, milligrams of morphine per population. We've actually become that. The number of high-dose patients, the number of total MEDs and people on chronic opioids, total prescriptions have all dropped by about 50%. And the clinicians are thankful, again, because of that pushing the policy, taking it out of their hands. Reduce cost. I think, we've spent a lot of money in this and time, but, direct costs in pharmacy alone, we've saved money, not to mention the indirect benefit with early data on reduced overdose deaths in some of our counties. And one would think that might transform into hospitalizations as well. Law enforcement, you hope, although there's that worry about movement to heroin, that's happening anyway. It's going to happen anyway, but we can't be that defense against heroin by prescribing. We do know a downside is we've had a lot of hearings. Appeals and hearings before administrative judges. But we've won most all of them based upon guidelines, policy, and the like. Another big win, of course, is the reallocation of clinical time. We haven't proven it yet, but one would expect. And we hope that our communities, with good, solid policy in place, will have a better time and easier time attracting primary care clinicians. And we know there's a huge shortage. And there's giant competition out there for primary care clinicians. And so in putting together a system for your community, it's attractive to new clinicians who know that they will necessarily be put under the same kind of pressures and difficulty in this area. So all these benefits, I think, will come to fruition. Some of them we know by data, others we assume or look to have that data developed. So our new targets, initial prescriptions, the poisoning and overdoses, we want to establish a new culture, in our clinicians and in our communities as well. That's a long-term thing, of course, and to watch it carefully to prevent the drift back, right? Because opioids, and we see it on TV all the time. I had a request for a prescription for one of the new MU antagonists to prevent opioid-induced constipation from a patient who wasn't prescribed opioids, but was
you saw it on the Super Bowl, I imagine.
but was using illicit opioids, and they were asking for a prescription to do away with their constipation. It's just like, oh my God. Talk about enabling. To prevent that drift. to treat
So,
suffering.
Marshall, we'll wind up. Any last point you want to make before I summarize and close?
No, and we do want to treat suffering. Our patients suffer a lot. There are a lot of reasons, not always just pain. So go after those social determinants, go upstream, go after suffering. It's not necessarily all about pain.
Dr. Kubota, thank you for such an informative talk. We really appreciate you joining us today. As a reminder, we will be sending out monthly summaries of future opportunities. We will have another event, a webinar on March 8th at noon with Dr. Kathleen Klin, and talking about how she was able to work with her community in Alameda County to bring clinicians together around common guidelines. We know this guideline work is tough, so we wanted to take a few stabs at it from a health plan perspective and Dr. Clannon from a public health county perspective. We welcome your input. If there's other topics or other experts you would like to hear from, we know this is tough work and we do want to connect you. So do reach out to us if there's individuals you'd like to talk to network and learn from each other, or if there's topics you'd like to bring us to our attention. We will be, we will release the recording and we think we'll put together a meeting summaries with some of the key points to make that available. Again, we'll be sending you more information soon. So thank you again, everybody, for attending, and we wish you a wonderful afternoon.